So unless you happen to be at a paediatric specific conference, the little people often get passed over and missing. So because we just happen to have the lovely Amanda at Avatar and the lovely Trish, we're going to spend an hour on paediatric vascular access today. So Amanda is an intensive care nurse, and she has just finished her PhD, which is big congratulations, and now has a big lot of work to do at Avatar. So what was your PhD on? It was the sticky stuff, wasn't
it? Was preventing complications associated with pediatric CVAD. So I think that seems relevant for here.
Just possibly she has a little bit of good knowledge. I say so. Amanda and Tricia. So Tricia is a nurse practitioner in pediatric vascular access. Are many of you around? And she looks after the paediatric chapter for Avatar, and her main clinical goal is the same as everybody else, just the same as in adults. We want to make sure the right device inserted the first time, by the right practitioner in the right vessel, and make sure that it leads to treatment. So Amanda and Tricia are going to do a tag team event now. So hopefully there won't be any costume changes, or will there be costume changes?
Decided yet.
Yes. Okay, here we go.
Hi everybody. Who here is scared of kids, pediatric in your hospital? Yeah, I'm not. I'm scared of the big hairy ones like that. Yeah, thank you, Joel. I thought you'd have my back there. Nothing more scary than an adult coming into a pediatric hospital and fainting. They could be having a heart attack. Kids don't have heart attacks. So I'm in my comfort zone. I thought that we would go through, because there is a chance that even if you're working in your beautiful adult tertiary facility, a 14-year-old boy will come in because he's had a car accident, something will happen, and a child will require care. And there is a lot that we can learn from each other. And basically, because I'm sick of hearing that there's no evidence about paediatric vascular access care and management, we have to do something about it. So as the lovely Kay said earlier, I'm a paediatric intensive care nurse, and that's really where I cut my teeth and got my interest in vascular access, because I used to care for these kids, mainly the oncology kids, that were going really well with their treatment. They'd be getting through their anti-cancer therapies, and then they'd get a bloodstream infection. And they'd come to me and they would be terribly sick, terribly, horribly sick. And I started to hear that maybe there was something we could do about it. A lot of these infections were preventable because they were associated with their vascular access devices. Okay? So I got a little bit ridiculously obsessed, and I started stalking Claire. She started answering my emails occasionally, which is great, and this is where we are at the moment, still developing lots of research to inform this practice. So we have formatted our presentation a little bit differently to the previous people. We're going to start off with talking about what we have, lots of high quality evidence to generate our clinical practice. So that means that, we can write these down and we can walk out to our clinical areas and we can apply them right now. And then Tricia is the practical one. So maybe we don't have the level of evidence that we want to, but this is what we should be doing now to promote safety and quality until we can develop evidence in the future. So I didn't want you walking away with today with a whole lot of questions and no answers. So that's the way we've done it today. So same as what Claire said, lots of people work for Avatar, and we really appreciate the support we get from our commercial sponsors. So there's our general disclosure slide. Thank you for all the partners here today. That's made a huge difference for having our seminar. So children aren't little adults despite their ability to propagate an impressive beard. There are huge amounts of issues when it comes to their development, as well as their how they deal with critical illness or chronic illness or acute illness physiologically, and this obviously impacts on their vascular access. So there is a reason why you're fearful, I get it, this has been echoed in all the guidelines that we look at. So if you look at EPIC, which I love, I think is a fabulous resource for us, and gets updated really quite regularly, they're very quickly to say this can't be generalised to children of under 1 year, or sometimes some of the others say less than 14 years. So, and that is because of very clever people like in the Cochrane collaboration who tell us this, that we can't generalise straight from the adult population to paediatrics. We have to learn in the process. So that's what we're going through today. this is why we're here, really cute little kids. So this is one of my friends, her little girl, Ollie, who Olive needed to have a heart transplant. Is anyone here from the Royal Children's in Melbourne? No, that's a shame. So Ollie spent a bit of time waiting for a heart transplant. Her big brother goes to school with my little boy. So obviously while Ollie was waiting for a heart transplant from her cardiomyopathy, she needed vascular access. There is possibly no one in the world who needs vascular access more than somebody waiting for a heart transplant. But what used to keep me up at night knowing this is that not only could her vascular access device promote her health, it could cause her significant harm. And that's where we all come in. We're here to promote her vascular access health during that short term, and also with the knowledge that she's likely to need vascular access devices for a large proportion of her life. But then if we look to see how well, not even the so obviously I've started off with an LVAD, but we also need to look at our peripheral IVs, how important they are. Tricia and I were starting to think, you know, those adults guys are doing terribly. I've seen Claire's talk before, I'm sorry, but I know that in Australia about 25-30% of peripheral IVs in adults are failing, and I started to really smugly think, but we'll be great. Those adults, they're terrible. Pediatric, we've got it all going on. We'll do an audit and we'll find out that our peripheral IVs, none of them fail. Of course, Tricia laughed at me, but we did an audit just recently on the IVs that nobody cares about. So, you know, people care about the ones inserted in emergency cares about those. The ones that are inserted in theatre, the anaesthetists worry about those. The ones that are inserted in ICU, somebody cares about those. But the ones that are inserted in our general wards after hours, so their care team has most of the time gone home, and it's the local poor, scared resident who's been in paediatrics for about a minute and someone just told them that they can't just give half a Panadol to a baby, and then they have to now insert an IV in this baby. They're the ones that we were worried about. That's where we thought maybe they'd fall through the gaps, and that's exactly what we found. We found that despite it took them, most of them needed at least 2 attempts to get in an IV. Several of them needed more than 5. We found that it cost around just over $40, sometimes up to $60 or $80 to insert each of these IVs. And we, at least every time that they went to insert this IV, it took them about 15 minutes of trying. So that's a long time. I don't know if there's any parents here, but that makes me feel very, very sad. That's a long time of a baby being held down, or a small child being held down while an IV is being attempted. And then, if we've gone to all that trouble, half of them stopped working well before treatment was completed. So that was, most of them were within the first 24 hours. That's because these clinicians after hours were worried about getting through their shift. So it's about getting the IV, that maybe it was holding onto their pinky, but that would get them through, they'd get them the next dose of antibiotics, but it wasn't going to get them through that device, what we would need that device for. And can I say what was causing the complications? So when they were failing, it wasn't like you were just talking about a blocked catheter that was no longer infusing, let's pop in a new one. It was causing significant harm for these children. So it was definitely something that was affecting them, and it was affecting their parents' experience as well. As soon as they knew, we interviewed them. So we followed them from when they had their line put in to when it came out, and then we interviewed them. And this is what they said, you know, that as soon as they hear their child needs a new IV, they start dreading it. You know, and these are normally children who have to come back again and again and again. So you know that if we break this relationship with them now, this is something that's going to cause us even more problems in 4, 5 or 6 years' time when they're teenagers and they're having to be held down to get their IVs. So, and if a parent who most likely hasn't, you know, got a healthcare discipline is starting to worry about how long will this one last every time an IV goes in, that's really not good enough. Everybody cares about money. It's one thing that we can say to our executives, I need more staff, or I need more expensive product, because we can be concerned about how much it costs. We just did some very simple maths recently and looked to see how much it costs to insert a tunnelled central line in a paediatric hospital, and it costs over $10,000. That's only from the time that they are admitted, assuming that they get admitted the same day that they're going to go and have their procedure, and the procedure doesn't get cancelled, of course, and then they go home quite soon after their admission. So that's a lot of money when we're considering that these devices in our chronically complex ill children, they can have, it's quite common for in a couple of years to go through 10 of these devices as they fail and fail and fail. That's a huge amount of money for our healthcare. So, and this is what goes wrong. I'm going to get to the happy stuff soon, I promise. But we did look to see why CVADs went wrong in paediatrics, and everybody's worried about infection. However, we also found out, of course, that they often fail because of occlusion, skin, a local infection, breakage. Breakage is a big issue. Dislodgement, another huge issue. Children don't know that they're not meant to pull out their jugular line. And we wake them up in intensive care now, which is really inconsiderate. Good for them, I guess, but it does cause problems when it comes to keeping their central line in the right place. So what we found is that 1 in 4 paediatric central lines stopped working before treatment is completed. So that's a lot. That's a lot of central lines. In Australia, that equates to, I think it was something like 25,000 a year, central lines going wrong, just in peds, so you can do the maths for adults. And this is what it looks like. This is my PICU at the Royal Children's Hospital. That doesn't exist anymore, sadly. But this is what a bloodstream infection in a child looks like, especially if they've got an underlying health condition. So I don't do this to pull on heartstrings or just a little bit. I do it mainly to make us feel like we can do something about this. This is a way to really impact on a child's life. This is something that can make a significant difference to a child and their family if we can prevent it. So stop keeping calm. So when we're speaking today, we've been doing this a lot about what's the lens that we look through with when we're looking at new practices in our healthcare system. So do we look for what my mate next to me tells me might be all right, or do we look through to see the quality of the evidence that's supporting these decisions? Like I said, I'm taking the easy stuff. I'm taking the stuff that has the high quality evidence. So we've really reached the top of this pyramid. And then Tricia's going to be looking at the more practical stuff based on lower levels of evidence. And we're going to focus it a little bit wider in that we're looking at how we prepare and plan for the patient through insertion management, and then what institutionally we can do in order to promote paediatric vascular access performance. So like I said, I'm at the top of the hill, go me. Tricia a little bit closer to the bottom, but yeah. She's shorter, so it really works out well. This analogy really has legs. So vapor coolants. Who here uses vapor coolants in practice? So that little spray prior to inserting a peripheral IV? No? So in adults now we have, so there was a systematic review done recently, so it's a cold spray, and it did find that in adults at least it definitely reduced pain, significantly reduced pain. However, when I looked for that, they did do a sub-analysis looking at peds, and we don't have that evidence yet. I think we actually think possibly about pain more in peds than you guys do in adults. Would that be fair? So we use a lot of EMLA, we use a lot of Angel, but actually possibly what we should be doing is a cold spray. But we need some more evidence for that. But at least it's something that we should all be thinking about now. You guys get to roll this out, go back and have a play. And for kids, I'm afraid we'll keep looking, but we can do this study, can't we, Joel? Next week, I'll give you a call. Ultrasound guidance. We've had lots of discussions about ultrasounds for CVADs, and of course we've got that great developing body of knowledge for ultrasound for peripheral IVs. People have looked at this in kids because, like you all, everyone's a bit frightened about how little those veins are. And there's been 2 RCTs done on this. While we can't say, what I'd love to stand up here and say is that if you use an ultrasound to insert that peripheral IV, it will last longer and you will have less complications. We're not quite there yet. What we know is that if for those difficult patients, you'll get it in faster, and you will be more likely to get it in, so about 7 times more likely to get it in first go in comparison to to not using it. And what it will do is provide you more chance to get it in the forearm. So, we've got that increasing body of knowledge to say that we should be looking for forearm placed peripheral IVs. Don't know if you've ever seen a toddler's forearm. They've got beautiful rolls hiding over the top of those forearm veins a lot of the time. So we have to look to see what technologies can go past the rolls. Only time in your life that a roll is a compliment, isn't it? So, and that's what the role of the ultrasound at the moment in paediatric is. I know Tricia tells me that she's forgotten how to do a peripheral IV without an ultrasound. Is that right? She hasn't. So hopefully, maybe in the future we'll get to that point. But it's definitely something we should be rolling out with confidence. We do need to train these clinicians on how to use that technology, though. You can't just say, "Congratulations, here's an ultrasound," because they will put a pot plant on it, and it'll be great for feng shui, and that's about it. You need to make sure that there is the capacity and skills to use it. Limb splinting. Do you use limb splints at all? What, your hand ones or the antecubital or more general? Yep. What about forearms? Use a limb splint on a forearm? Doesn't make much sense, does it? We've got these bones there, yeah? Kids, we do. Yeah. So, ladies lento a lot of the time? Are you? Really? You haven't. It doesn't make a lot of sense, does it? To put a limb splint on a place that has a bone. Yeah. So what we'll find is that a lot of people still put in a splint even on a forearm. We've only had one study now that looks at limb splinting full stop. So considering it's a practice that we use to prevent a lot of failure, peripheral IV failure. However, this study actually found it's in neonates. So I'll put that out there that neonates are weird, yeah. See through skin and stuff, and they move and they jerk and they don't do the same actions as a crawling toddler. However, a crawling toddler, no. What we did see here is that it didn't provide any benefit. What we do know is if we overuse splints and dressings, we stop being able to see a site. And that I have seen firsthand can cause significant harm if a person is unable to communicate their discomfort associated with their peripheral IV, and you can't do anything about it, then we can cause significant harm. So I'm not saying that limb splints are terrible. I just don't know if they work yet, and we definitely need to look at when we use them so that they're appropriate. So forearms, possibly you don't need them, and I'll be interested to see maybe they will help in if you're inserting it over a joint. It makes some sense, but that's something that maybe peds can learn from adults a little bit there. I don't say that lightly. However, securement isn't a simple one-size-fits-all thing. It's in peripherals, obviously we don't just insert peripherals in one spot, and we don't insert them on one size. It'd be great if we were just inserting them in the forearm, but we do need to look at the different technologies. Claire has done a fabulous job obviously already explaining this. So we are investigating all of these new securement and dressing technologies at Lady Salento at the moment, amongst other places. So hopefully we'll have more guidance. But I think we could almost be researching this forever, because every time we work out that something works, either a new technology becomes available or we start inserting an IV somewhere else, and we'll have to work out what to do for that one next. So I get the feeling we're going to need a real decision-making tree to help us decide between different products at different times or different clinical situations, and that's something that we're going to spend a lot of time developing. So I look forward to hearing what you all come up with as well. Ultrasound, we've said for peripheral IVs. Now we'll say for central lines. We actually even had enough studies. So pediatrics, no one studies because we're complicated. We've had so many studies we were able to do a meta-analysis. This is amazing in pediatrics. This doesn't happen. And we did find that, yay, who would have thought ultrasound does improve insertion success for CVADs. We see fewer mean insertion attempts. We haven't significantly reduced accidental arterial puncture. However, we do still have a large proportion of, you said in adults, Evan, that everybody uses an ultrasound for CVADs. I don't think we can say that yet in kids. There is this idea that we need to still be familiar with landmark insertion, but something we'll have to work towards in time. We even had a whole huge study of 1,400 patients, 1,500 patients in PICUs in the UK, which was super exciting, called the CATCH trial, and I love a good acronym. And this looked at antibiotic impregnated central lines. So it's thinking this is in the PICU, so they're those, jugular, or so those non-tunneled, percutaneously inserted CVADs, so standard care, so just a standard polyurethane CVAD, compared it to a heparin impregnated and an antibiotic impregnated. And we did find, they did find that antibiotic impregnated catheters decreased bloodstream infections by 60%. So that was a significant finding. And while we saw that the heparin was reduced it by some, it wasn't significant. So that means if you are involved in a PICU for those non-tunnel devices, they should 100% be using those antibiotic impregnated CVADs. So go home and tell your friends. Now, we haven't sorted this, as we heard earlier that from Kerry, that we don't really know about skin antisepsis 100%. We do know in adults that it's likely in intensive care at least that using a CHG, an alcohol-based product, will reduce your risk of bloodstream infections significantly. But what we also have in kids is this, which is not the nicest of photos, but it does demonstrate to you the complexity of the skin that's coming through pediatrics. So neonatal skin is a scary, scary thing. And then I would argue that all of you, I mean, you speak to nurses and we're all special, aren't we? I'm specialised in this, I'm specialised in that. All of your patients are special as well when it comes to their skin. So I bet you there is a comorbidity associated with your population. That means that a lot of the times chlorhexidine isn't going to be great. So just be aware that chlorhexidine sensitivity is around. So we've got chlorhexidine sensitivity, chlorhexidine allergies, and then you can just have any skin injury associated with these chlorhexidine-based products. So we see it a lot in neonates. We haven't really worked out how to do this in neonates. So we've just done a survey of all the Australian and New Zealand NICUs to find out how they're decontaminating their skin before we put in a peripheral IV. Everyone's doing something different. And a lot of them are applying chlorhexidine and having to clean it off with sterile water prior to insertion. And that seems to be the workaround that's the most common at the moment. I can't tell you if it's the most successful, but it's definitely the most common. But I can see why this is something that is a real complexity in all of our populations. So just take that into consideration. Bundles are fun. Bundles are fabulous. So when I'm talking about bundles, you know what I mean? So this is this idea that if we group a lot of interventions together, they'll be more successful than their individual components. So Pronovost did a fabulous job of how to prevent infections in intensive care associated with CVAD insertion. So let's wash our hands, let's use 2% chlorhexidine, let's get it out as soon as possible. And now we've got a meta-analysis that included children, which was very, very kind, which showed us that if you're using an insertion and a maintenance bundle, so thinking that the line continues after you've just first inserted it, it will reduce your CLABSI incidence. Now, bundles are mostly used in intensive care, I would say, at the moment. It's lovely to see how they are expanding. And Tricia's got something really practical for you about how to implement bundles in your institutions that you might like. But definitely your ICUs should be using bundles. Kerry has spoken about this, so the use of chlorhexidine impregnated dressings. So we've got lots of different dressing products that have chlorhexidine components in them. I'm not advocating for one over the other, just using them in intensive care, mainly because I dedicated too much of my life to reviewing all these articles. So we did find that it halved the rate of CVAD-associated bloodstream infections per 1,000 catheter days. However, 80% of these patient days were in an intensive care setting, so that really generalises it specifically to an intensive care population at the moment. And then if you look at those 4 big studies, only one of them was kind enough to include even any portion of paediatrics. So I would still say in a paediatric intensive care at the moment, CHG-based dressing product is your friend. However, we still need some more evidence to generalise that, because of this yucky slide where we have seen incidents of harm associated with the use of chlorhexidine impregnated dressing products. Just like we do when we use it for antisepsis, if we then leave it on a skin for a prolonged period of time, that we can see worsening skin irritation, and then that can result in the loss of the central line. So taking that into consideration within the decision making of does this dressing work or for this person, for this child, making sure that you take this into consideration. And what are the individual risk factors for bloodstream infection in comparison to skin irritation for this patient that's in front of me? I'm sorry, it's a complex one, this one, that we don't get to have a one-size-fits-all Band-Aid type solution. We have to really think about it. So I'm going to hand over to my friend Tricia now. She's going to go through all the other aspects of paediatric vascular access in 10 minutes.
Thanks, Amanda, and thanks everyone. I know it's getting late and you're probably all quite tired. So as Amanda said, she's gone through all the practices what we can do practically. So if you're going camping, you want to take me. I'm the practical solutions guy, which is quite funny because everyone knows I don't camp. So looking at the evidence pyramid that Amanda popped up, she really only discussed the top two. I've got the rest of them. And while your evidence or what you do in your facility might not fit into those top two small triangles, it doesn't mean that it's no good or it's useless or it has no value. It's simply that sometimes we just don't have enough randomised control trial evidence to implement within our practice. And it doesn't mean that all the others, including the ideas, opinions, are not worthwhile. They're most certainly worthwhile keeping in your armoury of vascular access maintenance tricks. So a lot of what I'm going to talk about today has kind of been touched on previously in all the adult slides, because what happens in adults and paediatrics do have similarities, but we just want to talk about how they might differ slightly in peds. So you have heard Evan talk quite extensively about the how to choose the right device. So I just want you to think about, do you have some kind of algorithm to help you choose a device in your facility? And who makes these decisions? Is it the clinician who's going to care for the device, or is it the person putting the device in? Because what a lot of places don't have is someone who's taken that overall responsibility for vascular access. So does somebody choose the device, then somebody puts it in, and then somebody looks after it, but who takes ultimate responsibility for it? And when you're choosing a device, do you use the same type of algorithm for all of your patients, or do you have something different for your difficult vascular access patients? And so we've heard DIVA discussed today. So I hope after you leave today that when you hear the word DIVA, you're not thinking about the latest pop star who makes some unreasonable demand, but instead you're thinking of someone like this guy, Dr. Chopra, who initiated the MAGIC guidelines, which Evan spoke about. And these came about because there is a massive increase in the use of PICs. And this was noticed that a patient is termed difficult, and I've heard this discussed a few times today. When someone's difficult, nobody wants to recannulate them, so let's put a PIC in. We know it's going to last, or we hope it's going to last, but it's going to have more chance of lasting longer than a peripheral IV. But does anyone know the risks of PICs? What's your failure rate in your institution of PICs? Do you know how you've increased your use of PICs in the last few years? So we just recently merged two children's hospitals in Queensland, and we've got a couple of years of data now. So we know that between 2015 and 2016, we had a 20% increase in PIC insertions, and that's massive for a children's hospital. So the great thing about the algorithms or tables in the MAGIC document, and this is only a very small portion of it, and I don't know how widely understood MAGIC is in Australia because it was essentially developed in the Northern Hemisphere, but they do have different tables or algorithms for your difficult patients as well. But again, keep in mind that this was developed for adult patients and hasn't necessarily been validated in children. So if you look at the peripheral IV, they suggest that that's okay for less than 5 days worth of treatment, and there's neutral agreement on whether a peripheral IV is okay for 6 to 14 days of treatment. Who in a paediatric facility thinks that's possible? We've already heard that it can take up to 5 attempts to put one peripheral IV in, and we heard that in this same hospital, peripheral IVs failed at least half the time. And over 30%, I think 38% of those failed within 24 hours. So that's, you know, almost daily cannulas for this length of time. And I'm not saying that that's the green light to go and put a PIC in. I'm just suggesting that we need to look at all the different options available to us and think about how we might be able to make that fit our patient population. Because the next suggestion is to use ultrasound-guided peripheral IV insertion. How many people have access in paediatrics to somebody who uses ultrasound guidance to insert peripheral IV? And then we know that there are certain infusions that the Royal College of Nursing say you should never infuse through a peripheral IV. And Evan touched on them earlier this morning and gave us some practical advice about how we can reduce the concentration of the infusions by diluting them. And so we all know that whenever we're using continuous vesican chemotherapy, which we don't infuse peripherally in children anyway, parenteral nutrition, and this is a big one because a lot of people don't understand the difference in parenteral nutrition. It's very broadly used and often people think you can infuse it peripherally, but you really need to know the concentration of the parenteral nutrition you're infusing. So if you've got anything exceeding 10% dextrose or 5% protein, it must go centrally. And same as the pH and osmolarity considerations. So what makes vascular access difficult in paediatrics? Amanda touched on this with the rolls, and this is a healthy baby. Why should they be difficult to insert a cannula into? So everyone would love this baby. I'm very proud of my healthy baby until they come to the hospital and the resident who's just started his term in paediatrics is asked to insert a cannula. So should that resident be having an attempt on this baby? Who thinks he should? So how do you think this baby should get a cannula? I don't work out of hours. So this is a difficulty that we're faced with. So we have discussed the use of algorithms to choose the device, and Evan and I basically shared slides, talked about the algorithm for choosing who should or how should you insert a peripheral IV. And I think this is a great way to look at vein quality. So if you've got excellent veins, you don't have that chubby baby, you've got, you know, a healthy 4 or 5 year old who has very visible veins coming into your emergency department, absolutely your resident should attempt on that patient, but they should also be restricted to what your hospital policy dictates on how many attempts. And as nurses, it's our responsibility to be the advocate for that patient and make sure they don't have any more attempts than those 2, because the registrar comes along and they have 2 attempts. And then this patient all of a sudden becomes a difficult patient because, you know, someone's failed 6 or 7 times. And then the next time they come into the hospital, the parents hand over or say to the resident, you know, it took them, you know, 8 times last time to get this in. It was only when they woke up the most senior intensivist that they finally got a cannula in. So this kid's labelled, but all that happened is that the wrong people attempted, and residents get scared off. I've been to see patients who need access and have been termed difficult, and they have beautiful veins. And as Amanda said, I don't consider myself an expert at blind insertion anymore, and I'll insert them blind because they do have easy veins. They've just been labelled difficult. So we need to be careful about making sure that we don't let people have too many attempts at inserting. So again, looking down this, if you've got 1 or 2 palpable veins, which that chubby baby in the previous picture had, then really we should be considering ultrasound. And ultrasound is not a team sport. You don't have your friend holding the probe because your right hand needs to know what your left hand's doing. You need to move your probe in time with your needle to make sure you have the best chance of success. But absolutely, inserting a cannula is a team sport, especially in paediatrics. You need to know who's inserting, who's holding, and who's taping. And quite often, you don't have the luxury of somebody to hold and tape. So the most important person in that scenario is whoever's holding. So the person who's inserting should then do the taping, because that person holding, they must continue holding until the cannula is taped in. So just some practical considerations to think about when inserting IVs into paediatrics. This is my nephew. He fell off a trampoline late in the afternoon. He managed to get seen through emergency and admitted in the evening around 9 o'clock. He's not having anything done until tomorrow, so they put a cannula in and they're going to put continuous fluids overnight on him while he fasts for theatre. So you can see this arm's broken, and they've put a cannula in his hand that he uses to suck his thumb. And they're going to want to check that every hour because they're continually infusing fluids overnight. How well do you think that's going to play out? So what I suggest is a distal forearm vein. keeps their arm free. There's no need to board it, there's no need to tape it up, and it's easily visible when you need to check it hourly. So we heard about the midline, so I won't go too much into detail about the differences in a midline, only that it must be considered a peripheral intravenous therapy tool. It's not a central line. It doesn't have the tip in the SVC, and this is what can happen if you confuse a midline for a central line. So this patient was transferred from the neonatal intensive care unit to our paediatric intensive care unit. So right about now you're all happy you don't live in Queensland and sending your children to our hospital. So it was well documented that people weren't sure, the handover wasn't clear whether this was a midline or a PIC, but then it just became referred to as a PIC. And how many people work in intensive care and know how many times a day children are x-rayed? Children get chest x-ray 2 or 3 times a day in intensive care. You'd think at one time they might have checked whether it was a midline or a PIC. Anyway, this child had multiple inotropes and other intravenous medications infused until it stopped working. And then we all know that tissue damaging medications don't present like this immediately. This was a couple of weeks down the track. It's just a slight burn, discoloration of skin until the flesh is slowly eaten away. And I'll flick through these quickly. Evan told us why the central lines are necessary for those more tissue damaging medications. The flow rates are much greater. They're even greater between the hand veins, the distal forearm veins and the axilla. So as you're getting closer to the heart, you are getting much more benefit out of the vascular access device you place. So another thing that Evan spoke about earlier, what can you see that's wrong with this picture? Apart from the bow without any hair. So that's a personal thing of mine. I hate bows and babies without hair. So you've got a neckline inserted on the neck and there is no real estate to care for this. So we talked about this large piece of real estate here when Evan was presenting earlier today. So everyone's a little bit scared about this because the jugular vein and the carotid artery are in such close proximity if you want to come at it at the angle that Evan suggested. But now we have this fabulous tool called Ultrasound, and again you can still see the proximity of the jugular and the carotid, and we also have very echogenic needle tips. So you can quite easily place your line in the jugular vein without breaching the other side of the vein wall, and here you can see blood freely aspirating. So it seems quite sensible to take that approach when we're inserting non-tunnelled jugular veins rather than trying to anchor it up the neck. PIC materials, so I'll go through this really quickly. We've seen multiple iterations of PICs. There's not been a lot of evidence around for the advancement from the silicone PIC to the polyurethane PIC to polyurethane with power injectable. As the plastics have changed, the complication profile has changed. So the silicone PICs, they occluded, they broke. Then the polyurethane PICs came in. Initially there was a lot of phlebitis associated with them because they are a much tougher plastic, but they did have a bigger inner lumen, so there wasn't a lot of as many occlusions. And now we have the power PICs, which have that next generation of polyurethane, so it's a lot softer and it softens with body heat. And then on top of that, Evan spoke briefly about the antithrombogenic PIC, which is sold as something that's really slippery, so nothing can stick to it. Platelets can't adhere to it, so thrombus can't form, bugs can't stick to it, so biofilm can't form. Sounds like the perfect PIC. So we're just waiting on some more evidence so that we can move that from my talk to Amanda's talk. And as we talked about briefly all day is the securement. We want to make sure we secure these because it has taken a lot of effort to get them in. In paediatrics, an IV cannula can be quite stressful to the patient, the parent, the healthcare staff. It can literally take 3 hours, we've seen reported in our audit, to actually get a peripheral IV device in. So that's a lot of stress to everyone involved. We want to make sure it's secured properly. And same for your more long-term devices, your PICCs, your tunnel cuff catheters. They can take a long time to insert, and they often require an anaesthetic. So you don't want to have to go and do that again in a few days' time. So think about hemostasis. Think about how you might stop the bleeding so that you don't take the dressing off the next day to put a new fresh dressing off and accidentally pull the whole PICC out with it. Try and ensure hemostasis at insertion. Think about security of the catheter, and also one size doesn't fit all. We've discussed this a number of times today. Individualise the type of dressing to the patient you've got. Needless access devices, yet more choice. I liked Claire's bracelet that she's going to make with it. I hope we all get one for Christmas. Additionally, with children, you need to think about how big the devices are. You can see along this lineup that there are devices that are much larger than others. So in your intensive care population, how is that going to look when you've got 6 or 7 of these hanging off the one device? It's going to pull itself out. Think about how secure they are. Are children going to pull them off and play with them? Is it just another thing for them to fiddle with? And cleaning. When I first came back to Australia, there was a lot of talk about 3 wipes. Everyone had to wipe their bung 3 times, but there's no evidence for 3 wipes. But what we do know is that we need to wipe it well. So a good 15-second scrub at least to make sure we get rid of all the bugs. So we can't just, wipe it 3 times and that's done, because we've hardly had any contact with disinfectant. And what are we going to use? Are we using alcohol? Are we using alcohol and chlorhexidine, or are we using the swab caps? So we've heard a lot of the talk about the evidence, or the upcoming evidence about these devices, but again, practically for kids, is this something that they will fiddle with if you're using the swab caps? And if you're using the chlorhexidine, do you need to make sure the hub of your catheter is protected so that the chlorhexidine doesn't get inside the hub and is accidentally infused? Flushing. This is something that when I came to one of these talks, I would want someone to answer. And now I'm here, and I'm sure you're all wanting me to answer flushing, and I can't. So what we do know is that devices need to be flushed. We don't know how frequently, but we might get some more of an idea if we can make sure that we have a standardised practice of flushing. If we flush regularly, or if we flush 4 or 5 times a day, we might get some kind of an idea of how many times is enough or too much. The use of pre-filled syringes, that's certainly going to reduce complications of potential infection. It's going to increase compliance, and it's going to be a lot easier to implement and make sure everyone's compliant. What type of flushing solution, we still don't know. Whether to reinfuse, discard, or reinfuse or discard our aspirates, again, we still don't know, but we need to individualise that to our patient. Why give a risk of infection or blood clot if we don't need to? If our patient has normal haemoglobin, what's the use of reinfusing? So we spoke about this, I think, earlier today. There's still no good evidence whether we should be using heparin or saline for flushing, but again, make sure you have a policy and make sure the flushing order is documented and that people are signing when they actually do flush, so that we know that flushing has happened. So we don't know we do know that we need to flush. We need to maintain patency. We don't know what solution, how much, whether we need to use a pulsatile method, whether it's intermittent or continuous infusion to keep the vein open, and how frequently. So then we look at locking solutions. What do we lock the devices with? Is there a different locking solution for different devices? Generally, there seems to be ports are locked with 100 units per mil of heparin. What's the length of time when a lock should replace a flush? The dialysis catheters are used so much more for blood aspirates and reinfusions, so they need something stronger. So we lock them with 1,000 units per mil of heparin. And then if we've had patients who have had recurrent infections and we've been able to salvage their device, or even if we want to put in a new device, but we want to prevent these kids from having more infections because they seem to be susceptible to infections. What role does toluidine citrate play in preventing those infections? There's quite a few randomised controlled trials, mostly in adults, but there are some in paediatrics, and we know from an observational study at our hospital that when we did prophylactically use Turolock on children who had previous bloodstream infections, they didn't represent with additional infections. And if we're trying to treat or salvage a line, do we use ethanol or antibiotic locks such as vancomycin and gentamicin? These certainly do work on being able to ensure that we can put concentrated doses of these antimicrobials in the catheter and have the best chance of trying to remove the sticky bugs from the plastic. But then we also need to make sure our line is aspirating before we decide to go down this track of therapy, because if your line doesn't aspirate, you can't remove these antibiotic locks from the patient, and you're going to have to infuse it. And how do you know how that's going to impair them systemically? So do they have renal failure? These sorts of things you need to consider before you go down the track of antibiotic lock therapy. And as Amanda suggested, we did implement a bundle of care for maintenance. There's a lot of evidence around the insertion bundles. So we looked at how the maintenance bundle might help in our hospital, because lines are not just cared for in the intensive care, they do venture out into the main hospital. And one of the big things that I found that this worked for me was it really improved compliance. So for a long time I tried to implement the boarded polyurethane dressing as a step up from the unboarded polyurethane dressing. I grew grey hair, lost my hair trying to implement that. The minute I removed all non-boarded polyurethane dressings and only had boarded dressings on the trolley, it was implemented quite easily and compliance was a lot easier. So if there's a particular practice that you're trying to implement, putting them on a trolley so that only the products that you want to use for your device maintenance are available and everything else is hard to find. So remove it as soon as possible. We can't emphasise that anymore. Even though children are difficult to put a line into, it's even harder to maintain additional lines if you have to treat the complication of the device. We'll just leave it in for a couple of days just to make sure we don't need it. All of a sudden they get an infection and we have to put in 4 or 5 replacement devices to treat the infection. And we're here for knowledge translation today. So it's not just good enough to do the research and put it into your policies and procedures. You need to make sure it's out there to the masses. They know what to do and that you're constantly surveilling and making sure that what you want to happen is happening. And if it's not happening, you need to feed back to people as soon as possible. You need to feed back on the spot so that they know the practice that they're doing wrong. And you need to benchmark both within your own hospital, nationally and internationally if you can. And it's possible to benchmark in paediatrics. There's enough big hospitals that we can share our data. And we need to talk about our rates. So if you know your rates of infection, you need to tell the different areas what your rates of infection are. So sometimes the best way to increase compliance is to have competitions between departments. There's always medical wards or oncology wards that are competing against each other. Tell everyone what your rates of complication, infection are, and hopefully you'll be able to achieve compliance by people wanting to reduce their complications. And in paediatrics, we have this great person sitting at the end of the bed. It's called a parent. They are the best advocate for their child. Teach them how to look after the device. Teach them what should be happening and empower them to speak up when something's not happening. And even teach the children. Children are great at knowing when something's not being done right. They just sap up information and they like to be able to tell you. They like to be able to feel involved as well. We had a patient at the Royal Children's Hospital who had primordial dwarfism, and so she was a really funny looking child because at 4 or 5 she still looked like she was less than 12 months old, and you'd walk into her cubicle and she was very aware of all the practices and what should be happening. The minute you walked into the room, she knew you. If she knew you, she knew that you were probably coming to see her, and so before she even said hello, she'd be like, "Wash your hands." So children are great to remind people to do something, and parents are also really good to make sure that their child's lines are being cared for well. So I'd just like to say thank you, and I hope we've answered as many questions as we can.
Nothing like getting back on time. Thanks, girls. So we're ready for afternoon tea is here, I believe. So we can have an early afternoon tea. Don't forget to get your trade passport signed so you can possibly redeem the cost of coming today through a voucher. And there's a box on the avatar table to put your trade passports in there. And on your tables we've put some avatar pens and some zingers and some post-it notes for you to go home so you can talk all about avatar. And when we'll be back, we'll have the panel discussion.